Hi guys, welcome to Pharmacy Peninsula, where today we're going to be talking about corticosteroids. Now, in particular, we're going to be talking about systemic corticosteroids, not so much inhaled or topical, which will be covered in a separate video. So, corticosteroids are essentially also known as steroids, are mainly anti-inflammatory medications used to treat a wide range of conditions. They're different from anabolic steroids, which are often used illegally by some people to increase their muscle mass. And so let's get straight into it. We have the two broad types, the two main types of corticosteroids, and that is the glucocorticoids and the mineralocorticoids. So if we assess each one of these, we'll start from the bottom. The mineralocorticoids mainly include fludrocortisone, and this mimics the hormone that's made in the body called aldosterone. So aldosterone itself is a mineralocorticoid produced in the adrenal glands, which sit right on top of the kidneys, and its job is to reabsorb sodium and reabsorb water, ultimately. So fludrocortisone essentially mimics that and does the same thing. Fludrocortisone also has some glucocorticoid effect, but mainly and significantly mineralocorticoid. And after all, fludrocortisone's anti-inflammatory activity is not really that relevant. As for the glucocorticoids, of which there is more of, they mimic a hormone called cortisol, which is also produced by the adrenal glands that sit on top of the kidneys. And now these act mainly on the glucocorticoid receptors, but they also have some minor mineralocorticoid effects too. In particular, hydrocortisone, and to a lesser extent, prednisolone and methylprednisolone, and then drugs like dexamethasone or betamethasone are completely negligible in terms of their mineralocorticoid effects. And like I said, mineralocorticoids are mainly for the reabsorption of sodium and water, but glucocorticoids are more for the anti-inflammatory and the immunosuppressant effect. So in terms of what glucocorticoids are used for, they are for treating allergic and inflammatory disorders, suppression of autoimmune diseases such as inflammatory arthritis or irritable bowel disease like Crohn's and ulcerative colitis. They're used in parts of some chemotherapies for cancer treatment, or if not for the treatment itself, sometimes in the supportive management such as dexamethasone, for example. And they're used in hormone replacement therapy in adrenal insufficiency (Addison's disease). Now, Addison's disease is where the adrenal glands essentially don't work at all, and so the cortisol needs to be replaced and the aldosterone needs to be replaced. So the cortisone is replaced by a glucocorticoid called hydrocortisone usually, and the aldosterone is replaced by the mineralocorticoid fludrocortisone, as we've just looked at. And in addition to Addison's disease, glucocorticoids can also be used in hypopituitarism. Otherwise, mineralocorticoids are used in, as we just mentioned, Addison's disease, but also in postural hypotension, where there's a sudden drop in the blood pressure, and we need to maintain that using sort of the fluid accumulation, which follows the sodium reabsorption, and that helps the blood pressure rise. Otherwise, you get patients who, for example, are sitting or lying down, and then as soon as they get up, they have a big drop in their blood pressure. Postural drop they call it, and once it goes beyond a certain number, it's classed as postural or orthostatic hypotension. People get dizzy, people get lightheaded, people can get faint, and they can't actually faint. So mineralocorticoids are good for that reason, not so much for the anti-inflammatory effect as the glucocorticoids are. Now, in terms of the mechanisms of action, I'll show you this via text, and then I'll show you a simplistic diagram I made. So glucocorticoids, as we said, mimic cortisol. They bind to the cytosolic glucocorticoid receptors, which are in the cytoplasm of the cells. Then they move or translocate into the nucleus and bind to glucocorticoid response elements on or around the DNA, regulating gene expression. And in particular, it upregulates anti-inflammatory and downregulates pro-inflammatory genes. What this means is that overall we have an anti-inflammatory effect. Glucocorticoids can also have direct actions on the inflammatory cells, including suppression of circulating monocytes and eosinophils, and they have some metabolic effects, as you can see at the bottom there. Here's the diagram. So we have the glucocorticoid at the top here, for example, cortisol, prednisolone or dexamethasone, moves into the cells, into the cytoplasm. The cytosolic glucocorticoid receptor is where it binds to, translocates into the nucleus, and then binds to glucocorticoid response elements, leading to upregulation of anti-inflammatory and downregulation of pro-inflammatory genes, giving an anti-inflammatory effect overall. Now, in terms of the mineralocorticoids, they mimic aldosterone, which we've mentioned, and they bind to mineralocorticoid receptors in the cytoplasm, but this time of the renal cells and the distal convoluted tubule of the kidneys. Then they enter the nucleus and they upregulate gene expression of sodium channels and sodium-potassium pumps on the epithelium of the tubule. This increases permeability and therefore reabsorption of sodium from the lumen of the nephrons back into the cells, and then subsequently back into the capillaries. Now, as for my simplistic diagram, we have the mineralocorticoids such as aldosterone or fludrocortisone, moves into the cell, binds to the receptor in the cytoplasm, the mineralocorticoid receptor, goes into the nucleus and ends up upregulating sodium channels between the lumen and the cell. So this is the nephron. Everything's going through, ready to be filtered, or is being filtered. And because of these sodium channels that have been upregulated, sodium is reabsorbed into the cell. Next, it also upregulates, as I mentioned, the sodium-potassium pump, and so not only is sodium brought back into the cell from the lumen of the nephron, but it's also brought back into the bloodstream, back into the body, and water often follows sodium too. So, and that's how mineralocorticoids work. Now, because it's a potassium pump, just in terms of side effects that we're going to look at next, if sodium moves into the cell, that means potassium moves out. If sodium moves into the bloodstream, that means potassium moves out of the bloodstream into the epithelial cell, and subsequently down its concentration gradient into the lumen of the nephron, and is ultimately excreted, and so we get a loss of potassium. And so when looking at the mineralocorticoid side effects, the first perhaps four are kind of obvious. Calcium I haven't mentioned, but we get sodium retention because there's an uptake of sodium, water retention because that follows sodium. As a result of the water, the increased water in the body, we obviously get hypertension, so higher blood pressure, and we get potassium loss because of that sodium-potassium pump, as we've mentioned. But we also get calcium loss, which we didn't really mention, but it's worth knowing. Now, in terms of glucocorticoid side effects, there is, in the long-term, diabetes, osteoporosis, muscle wasting, psychiatric reactions, peptic ulceration and perforation, and with high doses, avascular necrosis of the femoral head. I'm just going to go back a step. The BNF, the British National Formulary, seems to separate it into mineralocorticoid side effects and glucocorticoid side effects. But when looking at the individual monographs, you get an overall corticosteroid side effect monograph, which includes basically all of them. All these side effects. The ones not underlined are the ones we've just seen on the glucocorticoid page, and the underlined ones are the extra ones I've just added, so you can get a better overview. The only ones I didn't really mention are the mineralocorticoid side effects, which we've just seen, which are more specific to mineralocorticoids, just because we don't really see that those kinds of effects with glucocorticoids. But with all of these side effects here and the ones mentioned on the glucocorticoid page, in the long term, you could see them even with mineralocorticoids, despite their lesser effect on the glucocorticoid receptors. Anyway, in terms of the general corticosteroid side effects, adrenal suppression. So, if I go through these, in terms of the body makes cortisol, the body makes aldosterone. If you were to give the body a steroid, a glucocorticoid, for example, you're basically telling the body via a negative feedback loop to stop producing its own steroid, stop producing cortisol. And as a result, the adrenal glands atrophy. They get smaller because they aren't producing as much cortisol because they just don't need to as a result of this negative feedback loop. Fine, but that becomes dangerous because if you abruptly stop the steroid, then you can suddenly go into acute adrenal insufficiency because you do not have enough steroid in the body. And that's why in terms of when you're withdrawing off steroids, you have to do it slowly in order to ensure that the body can start to make its own supply of steroids, of cortisol. Now, in terms of infections, because of the immunosuppressant effect to some extent, it's worth being aware that you may be more prone to infections or an increased severity of any infections that you get. And subsequently, it's worth being aware that if you come into contact with anyone who has chickenpox or measles, it's worth getting seen just because it's risky, and if you're immunosuppressed already, you're more likely to have a worse outcome. And there can be immunoglobulins and infusions and such to help with these and in prevention of these. Certainly prevention of measles, and there's passive immunization with varicella zoster immunoglobulin if needed for exposed non-immune patients receiving systemic corticosteroids, or for those who've received them in the last 3 months with chickenpox. Now, with diabetes, if you're not diabetic, then your blood sugars could be slightly erratic, and it's something you should be aware of in the long term, and HbA1cs should be checked in the long term. Otherwise, if you are actually diabetic, you should be checking your blood sugars more often, just because of steroids increasing the blood sugar levels. In terms of osteoporosis, steroids can increase the risk of you getting osteoporosis, particularly in the long term, and this subsequently increases the risk of fractures, and later on near the end we'll cover who is eligible for bisphosphonates. You also get increased appetite and weight gain with corticosteroids, so it's the increased appetite that leads to the weight gain. Just be aware of it. You get muscle wasting, so be aware of any other medications which can cause muscle aches, pains and issues, such as myopathy with statins, for example. You could get psychiatric reactions, and in the short term you can get mood changes, for example, so irritation, anger, but not quite psychiatric reactions. But if you do get anything such as paranoia or depression or suicidal tendencies, it's very, very worth chatting to a specialist and essentially seeing if it's worth continuing with the steroid or if there's something else that can be done, because that's quite a big side effect. In addition, peptic ulceration, perforation, and GI bleeding in general is a risk. We've mentioned the high dose associated with avascular necrosis of the femoral head, and high doses can lead to Cushing's disease, which is where there's too much steroid in the body. And the last two, the skin changes, such as those mentioned there, and then cataracts and glaucoma. Now, in terms of the side effects we've just mentioned, most of them are long-term side effects, and if someone's coming in for a prednisolone for a COPD exacerbation that they're meant to take for 5 days, you're not going to tell them about osteoporosis, diabetes, or Cushing's disease. No, not really, because they're long-term side effects. But in terms of common short-term side effects, you'll want to tell them about insomnia. They're not going to be able to sleep if they take the prednisolone, the steroid, too late, so take it earlier on in the morning. In terms of gastrointestinal upset and nausea, make sure the patient takes it with or after food, and just be careful with other over-the-counter medications like ibuprofen and other NSAIDs. It can lead to mood changes, and people are often a little bit angry or irritated. Fine, not too big of a problem. They should be able to manage it, but if it leads to psychiatric changes, that's where you need to seek medical attention, as mentioned. Increased appetite in the short term could be, and for example, if you've got an increased appetite and you're eating much more for 7 days, you could get increased weight as well, so weight gain. And perhaps in a clinical setting, hypertension might occur in terms of some fluid retention with mineralocorticoid activity. As mentioned, if any, in terms of the glucocorticoids, it's probably hydrocortisone that might cause that. Otherwise, fludrocortisone could certainly cause that. But more relevant in a clinical setting, because the patient's not really going to understand what hypertension is, or they're certainly not going to be able to feel it. So, in terms of important advice, the Medicines Healthcare and Regulatory Agency has released a few warnings, such as the rare risk of serous chorioretinopathy, which is just where fluid accumulates under the retina, causing a serous detachment and vision loss, essentially. So if there are any vision changes, it's worth seeing an ophthalmologist whilst you're on the steroids. Otherwise, MHRA warnings around steroid emergency cards, which we'll cover a little bit later on. And that's just to prevent issues in people who have adrenal crises. The MHRA also happened to mention methylprednisolone injections containing lactose, leading to serious allergic reactions in those with cow milk allergies, but I suppose that's a given. If you inject a product that someone's allergic to inside of them, that's going to be an issue. And just some extra points. Steroids can lead to growth restrictions in children, and in pregnancy and breastfeeding, steroids are generally safe, because the benefit outweighs the risk, but it's worth monitoring for fluid retention in pregnant women. That said, this pregnancy and breastfeeding conclusion came as a result of a systemic corticosteroid review, I suppose, back in 1998. The only thing really to mention perhaps in pregnant women is that if women are taking prednisolone doses of up to 40 milligrams, it's probably not an issue. If they're taking doses higher than 40 milligrams a day, the baby may need to be monitored for adrenal suppression. So, we've just talked about some of the side effects. So how can we avoid them? Taking a single dose in the morning, for example, will definitely avoid insomnia, or to the best extent. Prescribers should try and give the lowest effective dose for the shortest time period. If you can use local treatment, for example, a cream instead of a tablet, or an inhaler instead of a tablet, even better, so better than systemic treatment. Sometimes alternate day administration is recommended, where 2 days worth is taken on one day, and then you skip a day, and then 2 days again, rather than taking it every single day, may be better for patients. Something worth discussing with these specialists. And lastly, intermittent courses may be utilised too. So now we've covered basically what corticosteroids are, and we've covered how they work and their side effect profiles, in addition to how we can reduce those side effects and sort of MHRA warnings and other little facts around sort of children, pregnancy and breastfeeding. Now we're on to a different section. Now we're going to be talking about the adrenal glands themselves, and in particular we've got to look at avoiding abrupt withdrawal of steroids if they fall into one of these categories. And that is because, as I mentioned, when you're taking steroids, you're going to have adrenal suppression because your adrenal glands are going to be smaller because they're not making enough steroids because you've already got enough steroid in the body, such as prednisolone, activating that negative feedback loop. And so with suppressed adrenal glands, if you suddenly stop the prednisolone, if they fit into one of these categories, then your body's not going to have cortisol. It's not going to have steroid in the body, and you're going to have an acute adrenal insufficiency. So avoid abrupt withdrawal of steroids if you're using any dose, essentially, for long term, which is greater than 3 weeks, or if you're using high doses, which is more than 40 milligrams equivalent of prednisolone for more than a week. If you take repeated doses in the evening, if you've had recent repeated courses, or if you've had a short course of steroids within a year of stopping long-term steroids, because adrenal suppression can last up to a year, basically, after you've stopped steroids, so it's still a risk. And if you've got other causes of adrenal suppression present. Now, in terms of the 40 milligram prednisolone thing, here's some dose equivalency. So 5 milligram of prednisolone is equal to those. So if you need to, you can calculate if someone's taken a high dose for more than a week and if it needs to be weaned off rather than abruptly stopped. So in the top right hand corner we can see a picture of the kidneys, and there's the two kidneys, and we see the adrenal glands on top which produce aldosterone and cortisol. So in terms of what adrenal suppression is, I have explained it. We have the hypothalamic pituitary adrenal axis here, or the HPA axis. Hypothalamus makes CRH to the anterior pituitary, which makes ACTH, which activates the adrenal cortex, producing cortisol. When there's enough cortisol, negative feedback loop is activated to tell the hypothalamus and anterior pituitary to stop making cortisol because there's enough of it. So when you have prednisolone into the mix, or a steroid, it tells the body, basically activates the negative feedback loop and says stop making this. And regular administration of steroids beyond the criteria I've just showed you, such as any dose for more than 3 weeks or a high dose for more than a week, leads to this negative feedback loop activation. And as a result, the adrenal cortex atrophies, get smaller, cortisol isn't produced. If you abruptly stop, there's no time for this cascade to start working again, and so you get acute adrenal insufficiency, where your body's severely lacking steroid when it needs it. But if you wean down slowly, let's say for example if you're on a high dose, wean down by 5 milligrams every week, all the way down to physiological levels, so around 10 milligrams, and then an even slower reduction, obviously under specialist supervision, then this gives the body time to start producing its own cortisol again. So by the time you come off with that very, very slow wean, your body's already making enough to make up the deficit, and then by the time you come off, you'll be making enough to for your body to make do. Now that's obviously in someone with working adrenal glands. And people with Addison's disease, where the adrenal glands do not work, that's not how it works. So you need to be on steroids for life, basically, as we've mentioned. I've mentioned the fact that adrenal suppression can last up to 1 year after stopping steroids as well. Next. So what is acute adrenal insufficiency? So we've touched on it, and it's when not enough cortisol and often aldosterone, because that's also made in the adrenal glands, is being produced by the adrenal cortex or the adrenal glands. In terms of symptoms, people may feel, they'll be hypotensive, and that might lead to lightheadedness, dizziness, weakness, nausea, vomiting, and abdominal pain, in addition to sweating and loss of consciousness, and ultimately it can lead to seizures, coma, and death. So treatment is very prompt administration of IV or intramuscular injections of hydrocortisone as soon as possible, and hospitalization is required, as well as support for blood pressure. It's important to carry a steroid card, which we'll cover next, just in case of emergencies, so people know that you need hydrocortisone injections. That is if you, for example, if you have Addison's disease and if you miss a day's worth of doses, then you'll definitely need to inject, because otherwise your body's not going to have any steroids. So otherwise, yes, so even if you don't have Addison's disease, if you're just taking steroids long term, your adrenal cortex, your adrenal glands are suppressed. You've got adrenal suppression. Stopping them abruptly can lead to this, which is a massive, massive risk, and you could die from it. So just be aware of that. In addition, as I mentioned, so if you do have Addison's, if you have vomiting, diarrhea, so obviously the steroid tablets aren't staying down, that is when you'd also need to inject hydrocortisone and try and get yourself admitted to hospital, hopefully, just to make sure you're looked after. So here are the two cards. We've got the steroid treatment card and the steroid emergency card. This one's been around for a while, but the emergency card's more recent, but they've both been around since around 2020. So the blue card carries, the one on the left, carries a series of instructions for the patient and informs healthcare professionals that the patient is on a steroid. It should be given in theory to people who go beyond the abrupt withdrawal criteria that I showed you. But like it says on the front, if you've been taking steroids for more than 3 weeks, then you should not abruptly withdraw, and that, or basically you should have this card with you. Likewise, I think it depends on the trust as to who gets them. But I think anyone who falls beyond the abrupt withdrawal criteria that I showed you should get one, because they should not be withdrawing steroids abruptly. Okay. The other card, the steroid emergency card, has been developed for patients with adrenal insufficiency and steroid dependent who are at risk of adrenal crisis. So normally it's for people with conditions like primary or secondary adrenal insufficiency, which would be, for example, Addison's disease, where the adrenal glands don't work at all, or secondary, where the pituitary gland isn't working very well. And again, it's just to support healthcare staff with the early recognition of patients at risk of adrenal crisis and how to treat it in an emergency. General advice for the patient in the short term: short course of steroids, so tell them about the side effects, the common ones: insomnia, mood changes, GI upset, maybe increased appetite, as well as the risk of psychiatric reactions and any other reactions you might deem significant where they'll need to seek medical attention. They should have a patient information leaflet, and just advise them that within the next couple of days, generally 1 or 2 days, if they're on a short course, they should start to feel better in terms of reduced inflammation. In the longer term, risk of infections is important, adrenal suppression is important, and not withdrawing the corticosteroid abruptly, otherwise leading to acute adrenal insufficiency. And consider steroid treatment cards and steroid emergency cards depending on the situation. Quick note, patients who are currently ill with an intercurrent illness, what happens normally is that the body produces more cortisol to support them. In someone with adrenal suppression, that doesn't happen because you've got synthetic corticosteroid going in you. As a result, since your body's not going to produce the cortisol, you may lead or go into acute adrenal insufficiency again, and as a result, people often double their dose of steroids, certainly with prednisolone, for the period that they're ill, and then they reduce back to the normal dose. So just be aware of that. In terms of interactions, I suppose NSAIDs are one of the main ones because they increase the risk of peptic ulceration and bleeding. But be aware of other drugs which can also increase the risk of bleeding in the stomach. Then there's the beta-2 agonists, agonists like salbutamol. There's theophylline, loop and thiazide diuretics that in conjunction with prednisolone or steroids, corticosteroids may cause hypokalemia, low potassium, which is dangerous in and of itself in terms of heart rhythms. Then there's the cytochrome P450 enzyme inducers such as phenytoin, carbamazepine and rifampicin, which as inducers, they induce the metabolic enzymes to work more and work faster, thereby breaking down the prednisolone more and reducing its effect. And corticosteroids can also reduce immune response to vaccines. Lastly, the monitoring generally depends on what's being treated. There's no specific monitoring for steroids when you're using them. But for example, in asthma, you might want to check peak flows. If you've got inflammatory conditions, check the C-reactive protein and white blood cells to make sure that the steroids and or any other treatments like antibiotics are working, or other antibiotics. If you've got infections, inflammatory conditions, more like, for example, in arthritis, where you want to see that the C-reactive protein is going down, or the ESR, for example, is going down. So just be aware, each condition has its own range of things that you want to monitor for. Not so much specific to corticosteroids themselves. However, in the long term, you may want to look at the HbA1c in terms of diabetes risk, and you may want to look at DEXA scans to review patients who may develop osteoporosis. And on that note, I said I'd come back to this, and in terms of starting bisphosphonates in patients who are on steroids, high dose of steroids are considered to be not high dose, but rather anyone taking greater than or equal to 7.5 milligrams a day. If you're a man and you take that much or more, you could start a bisphosphonate, or if you're a man 70 or over and you've had a fragility fracture, it's worth starting as well. Otherwise, if you're a woman greater than 70 years old, you can start a bisphosphonate, or if you're a woman who's had a previous fragility fracture and you're over 70, you could start one, or if you're taking large doses again, greater than 7.5 milligrams a day, you can start a bisphosphonate. Otherwise, anyone taking bisphosphonates at 7.5 milligrams per day or more for 3 months or longer is also eligible to start a bisphosphonate. So that's worth mentioning, just because obviously the older you get, the greater the risk of osteoporosis anyway, and if you have it, it also increases the risk of fractures, and as you get older, the risk of mortality with that also increases. So women are at greater risk of osteoporosis anyway, particularly postmenopausal women, which is why women who are greater than 70 years old are particularly at risk. In summary, we've covered what steroids are, how they differ to anabolic steroids, and we've covered the two broad types, the glucocorticoids and the mineralocorticoids, and what they are used for. We've covered their mechanisms of action in terms of the written text as well as diagrams. We've covered the short and long-term side effects of corticosteroids and how to minimize them, as well as what the BNF suggests are specific side effects to mineralo and glucocorticoids. We've covered general advice in in terms of MHRA warnings, advice on children, pregnant and breastfeeding women, as well as the doubling of doses in intercurrent illness when using steroids. We've talked about reducing the minimization of side effects, which I think I've just mentioned, but just to reiterate, we've talked about avoiding abrupt withdrawal of steroids and the importance of steroid cards, and thus we talked about adrenal suppression and acute adrenal insufficiency and its importance in steroid therapy. We've touched on interactions as well as monitoring. I know it's probably a longer video than normal, however, I hope it has been useful. Please feel free to go back again and take a look at it, because there'll be things that you didn't quite catch the first time round that you catch on the second time round and that you understand much better. Make some notes, study well, and have a great day, guys.